Hello. This presentation is an exploration of issues in schizophrenia identification, symptom management, and advocacy within the Black community. Before I start, I'd like to briefly introduce myself and my project. My name is Rahi Dhoke, and I'm currently an 11th grade student at Bothell High School in Bothell, Washington. My mentor Phil helped me research this topic. Behavioral health is a field I have long wanted to pursue, and schizophrenia is a mental disorder that I've always found interest in studying. I'm also deeply passionate about bringing reform to the healthcare system, and this is a particular facet of medical care that needs to be addressed and improved. In the identification and treatment of schizophrenia, a severe psychiatric diagnosis, extant work has reported significant disparities when comparing Black individuals with their white counterparts. This presentation reviews how inadequate medical care can result in a pronounced negative quality of life in Black people living with schizophrenia. Creating space for knowledgeable discussions about the ways in which medical attention is deficient for Black patients can stimulate social reform in the field, which can forge an enhanced healthcare system, and in turn, inform social change in other oppressive systems. Risk factors for developing schizophrenia include genetics, other psychological disorders, and substance abuse. Specifically within the Black community, manifestations of racism can lead to intergenerational trauma within individuals, which develops the disorder. As the high overdiagnosis of schizophrenia within the Black community suggests, simply being a Black individual presents a risk for a schizophrenia diagnosis. Due to racist historical policies such as redlining, Black populations have received less neighborhood funding, resulting in fewer resources in schools, both of which can impact the amount and quality of education that Black individuals receive. These inadequate materials can lead Black people toward a school-to-prison pipeline that is conducive to the development of a substance use disorder. Black neighborhoods are also more likely to include chronic stressors that can add to and worsen pre-existing medical conditions, such as the over-policing in these communities that leads to disproportionate incarceration rates. This cycle of oppression not only extends itself to mental health disorders, but also adds to etiology, which refers to the causes of a schizophrenia diagnosis. These systemic disadvantages, along with the mental health stigma toward and within Black communities, can generate poor outcomes and even lower rates of happiness compared to white communities. Physicians tend to categorize symptoms differently across racial groups. For instance, a study done by Hoffman and Associates in 2016 found that white medical students and residents endorsed inaccurate views about biological differences between Black and white patients and believed that Black patients experienced less pain. Unsubstantiated medical beliefs, such as these and other stereotypes, inform physicians' diagnoses, indicating why, in part, there is an overdiagnosis of schizophrenia within the Black community and a higher rate of schizophrenia diagnoses in Black communities compared to white ones, despite there being no genetic evidence suggesting that schizophrenia symptoms are more prevalent within the Black community. In another paper, Mallinger and colleagues suggest that Black people with schizophrenia are less likely to receive gold standard antipsychotic medication, indicating a clear disparity in treatment. Moreover, this failure of the healthcare system has created another avenue for sanist oppression, which is the systemic discrimination against individuals seen to have a mental disorder, to bolster itself against Black individuals, thus supporting the stigma of mental illness in marginalized communities. Physician bias may reveal itself in a physician's beliefs about the demographic of patients that they are treating. Stereotypes such as the incorrect idea that Black individuals are inherently more aggressive and untrustworthy than white individuals correlate with the disparities mentioned previously. Simply put, routine emotions shown by Black individuals may be wrongfully understood as symptoms of schizophrenia. This stereotype was even backed by the DSM. The 1974 printing of the DSM-2 focused on hostile subtypes of schizophrenia within Black communities, leading to an association between Black individuals and schizophrenia. While this taxonomy issue has been revised to exclude these perceptions within diagnostic criteria, the perception of Black individuals as dangerous and dishonest has lingered in various forms. Additionally, sanist ideas link these biases together, as people with schizophrenia may be discerned as violent and dishonest, despite diagnostic criteria not supporting these biases. These faulty associations may be yet another cause for the overdiagnosis of schizophrenia within Black communities. Researchers of schizophrenia have also underrepresented Black communities in their clinical studies, thus disregarding specific risk factors for Black people that may contribute to the presence of schizophrenia, such as intergenerational trauma. Furthermore, this lack of inclusion within clinical study samples does not allow for the results of the study to be generalizable to whole populations. The viability of provided treatment is known to be influenced, in part, by the empathy shown by medical providers. Roberts and Associates observed that an empathy gap may exist for Black people and African Americans as compared to white people. This lack of empathy in clinical spaces may not only result in wrongful diagnoses and substandard treatments, but also in the discouragement of Black communities from following medical advice altogether. Adding on to the taxonomy issues of previous DSMs, physicians have been taught that Black patients are, for example, in less need of pharmaceutical drugs and have thicker skin. Consequently, physicians are taught the biases that form this empathy gap, leading to disparities in care for Black communities. Historically, unconsenting Black communities have been used as test subjects for researchers to experiment on. The Tuskegee syphilis study and many other medical exploitations of the Black community have resulted in a deep mistrust of the healthcare system within the Black community. This history demotivates Black individuals from seeking treatment, and the issue is also related to the underrepresentation of diverse individuals in clinical studies. When scouting for voluntary trial participants, many researchers do not make Black individuals feel comfortable enough to take part in their study, which may be why Black individuals make up only 5% of clinical trial participants. As of 2018, only 5% of doctors in the United States were Black, compared to almost 57% of white physicians. This lack of diverse clinician and researcher groups can further discomfort Black individuals and discourage them from participating in medical research. Moreover, Goodcross and Grimm found that there was a level of connection between Black therapists and Black patients, leading many Black clients to prefer a Black clinician. According to the 2021 National Survey on Drug Use and Health, only 39% of Black individuals and African Americans received mental health services, compared to 52% of white people, despite both groups having similar reported rates of mental illness. Black individuals are also much less likely to seek care than white individuals, but more likely to be given less evaluation time with clinicians if they have found treatment. Furthermore, Lee and colleagues found in 2014 that Black schizophrenia patients experienced significantly less improvement in symptoms of schizophrenia, negative and general psychopathology symptoms, as well as functioning abilities than white participants. Indeed, this lack of resources shared by physicians may contribute to these low treatment effectiveness rates. Extant work has suggested a bidirectional correlation between unemployment and psychosis. According to a 2021 report by the Bureau of Labor, joblessness in Black communities is particularly high. Joblessness is also linked to poverty, and as Black communities generally already have less wealth than their white counterparts, impoverished Black communities are less likely to have the resources needed to fund medical treatment. In 2012, Boyle and Associates found unemployment and the development of psychosis to be correlated. Further, this relationship was found to be stronger in Black Caribbean and Black African individuals than in white individuals. Schizophrenia symptoms may also make working more difficult. In fact, recent work has also shown that schizophrenia symptom severity increased, so does less success in finding a job. To add to this complication, Black individuals already face discrimination when applying for jobs, and in all, unemployment itself is correlated with poor health. Mental illness is also correlated with houselessness, which is another trigger for psychosis. When they are not living close to medical facilities, many people may find it difficult to travel large distances to find medical care. Also, predominantly Black neighborhoods have more public health closures and fewer primary care physicians than predominantly white neighborhoods, and many lack proper resources for effective medical treatment. External factors can prevent Black individuals from seeking care, but so too can stigma from within the Black community. Some Black individuals believe that they will be discriminated against for mental illness and feel uncomfortable speaking about their mental health, sometimes even within their own social circles. This issue can be tied back to unemployment concerns, where being diagnosed with a mental health condition can make finding a job more difficult. Schizophrenia is disproportionately diagnosed in Black communities, and this discrimination is perpetuated by physicians who do not give the same care to Black patients that they do to white patients, resulting in a reluctance from Black individuals to seek treatment from an already untrusted healthcare system. Black communities are underrepresented in clinical studies, and Black clinicians are few, which contributes to poor treatment outcomes. Unemployment, houselessness, and stigma all hinder Black individuals from finding treatment as well. These structural systems of oppression work in conjunction to keep Black individuals in a cycle of oppression that does not allow them to find proper care. For the healthcare system to properly serve its patients, these issues must be addressed and improved upon. Thank you for taking the time to listen to my presentation. If you have any questions, feel free to email me at the email shown here.